Good afternoon, everybody. My name is Jordan Dozier. I'm a thoracic surgeon here in the city at Oxnard. Thank you, everybody, for being here. It's been a real privilege to serve as the lung block chair here for CAGLA. I've been involved since 2021. And it's been really incredible to watch the organization grow and watch the meeting grow, not just in size, but in depth, discussion, and collaboration. And one of the things that I've really enjoyed about being a part of this organization is strengthening the relationships with new physicians as well as old physicians that I've known in this cancer space. And so today, what we're going to do is try to bring you inside a true multidisciplinary conference. You're going to hear multiple perspectives from not just thoracic surgeons, but interventional pulmonologists and medical oncologists. And we're going to be highlighting the teamwork it takes to take care of these cancer patients. It's these different lenses that make the discussion richer and really help us to learn and grow in our individual practices. So we're going to hear from some of the best, not just regionally, but from across the country that they've come in to talk to us. So I'm really excited to hear what everybody has to say. So first up is Dr. Abdelghani. He earned his medical degree from Jordan University of Science and Technology, completed his residency here in Louisiana at Baton Rouge General, and his pulmonary and critical care fellowship at Tulane. He then went on to do his interventional pulmonology fellowship at Harvard and trained at Beth Israel Deaconess and Mass General. He's now assistant professor and director of interventional pulmonology at Tulane, and he has clinical and research interests in peripheral lung nodules, malignant airway obstruction, as well as cryobiopsies. And today he's going to be talking to us about the diagnostic and therapeutic modalities in interventional pulmonology. Thank you.
Hey, good afternoon. Like I said, I'm Ramsy Abdelghani. Thank you all for making the time and coming out here. So I kind of want to give a little perspective on interventional pulmonology, how we help the thoracic surgeons and medical oncologists, and how we play a role in the treatment landscape in taking care of cancer, helping diagnose and palliate lung cancer. So points of discussion, I want to talk about what interventional pulmonology is, some of the diagnostic tools that I found very valuable in our field and to help minimally invasively diagnose and treat and help palliate lung cancer, and some therapeutic tools as well. That way these patients, when they come in more short of breath, we can help relieve that difficulty breathing and have them more robust and be able to get treatment under y'all's care, and future directions, of course. So interventional pulmonology is a procedural subspecialty. It's minimally invasive and aimed at diagnosing and treating various pulmonary and pleural diseases. It takes a patient from uses advanced diagnostic and therapeutic interventions with bronchoscopic and pleural techniques. How you get there, I'm a medicine doc, so I'm a little different than our surgery colleagues. I did 3 years of internal medicine, followed by another 3 years of pulmonary and critical care, and finally a 7th year of interventional pulmonology. So a longer road than it probably should take, but this is kind of the current way we do things here. So the kind of the landscape of what we treat, it's a wide array of things. Mainly, my passion, my focus is helping diagnose lung cancer. We can also help with people who have difficulty breathing in COPD and bullous emphysema. If you have tracheobronchomalacia or excessive airway collapse, we can aid in that as well. Any kind of fistula, typically we're part of the treatment team as well, whether it be tracheoesophageal, bronchopleural, or alveolar pleural. In hemoptysis, again, typically we're part of the team as well, helping get culled and helping localize and stop the bleeding and queuing it up for interventional radiology or thoracic surgery to get the final treatment. ILD, chronic bronchitis, again, we won't mention in this talk, but again, we can kind of help encompass most of the respiratory diseases. So some of the advantages of bronchoscopic biopsy, of course, I'm biased because it's what I do for a living. I don't do CT-guided biopsy. So it's a minimally invasive procedure, much like CT-guided biopsy. It's typically an outpatient procedure. There is minimal risk of complications when compared to CT-guided biopsy. Typically, traditionally, the data shows around 20% pneumothorax rate for CT-guided biopsy because you're puncturing the lung every single time. We're going inside the lung or inside the balloon, so our risk of pneumothorax is significantly less. It also can help our surgery colleagues. If there's a small nodule, may not be able to feel with their hands or with the robotic surgical tool like the Da Vinci. We're able to mark these areas with some dye or a fiducial, depending on the surgeon's preference, to help localize these lesions so they can minimally invasively take these out and can preserve lung tissue. At the same time, we were able to basically, after we biopsy the nodule, we're able to also stage the mediastinum, being, providing a one-stop shop where we can diagnose and stage the lung disease or lung cancer, and that can help expedite the patient's care, decrease time from diagnosis to treatment, and give a better picture for our radiation oncology, medical oncology, and thoracic surgery colleagues. So navigational bronchoscopy has been around for many years. It came out as electromagnetic navigational bronchoscopy, and now with the advent of the robot has become more accurate and safe to do. Essentially, I think of it like a lung GPS, right? I think of it like a big old oak tree. I always tell my patients to go down the trunk, down the branches, and I'm going to one specific leaf on that tree. You can see there's hundreds of branches, many bifurcations, can be very challenging to get to. So having a device or platform to help us get there is very helpful. And came the robotic bronchoscopy. Data shows the average diagnostic yield is about 84% compared to CT-guided biopsy between 80 and 90%. If you add advanced imaging, basically you have CT-guided biopsy by an interventional radiologist, and now we offer CT-guided bronchoscopy by an interventional pulmonologist. And that increases your diagnostic yield to around 95%. This is kind of the console we use that we can control, and it can be done. It's kind of the little brother of the Da Vinci. We kind of are able to do this as in an outpatient setting. This is a screen of how it looks like when we plan our cases based on the device that we use. The robot will segment the airways for you, but you have to make the plan itself. You take that plan, put it on a USB, plug it into the device, and the day of the procedure, it'll help guide you to that location. So we've come a long way. Back in the day, it was, CT-guided biopsy was king, right? It had the highest diagnostic yield, and it was the one that everyone kind of referred to as the culture that was provided back then. We got our diagnostic yield from conventional bronchoscopy is quite low, thus most bronchoscopists would send to IR for biopsy. Once we got electromagnetic navigation, we got a little better, but still, a lot of times I would find myself sending to interventional radiology, and I'd find myself asking the question, could I even get to this? It looks really challenging. Let me do the best for the patient, send it away. Now with robotic bronchoscopy and advanced imaging, I'm able to get a higher diagnostic yield for bronchoscopic biopsy, a lower complication rate, and really the culture has changed from can we do this to should we do this? We can get to anything now, but should we be biopsying a 4-millimeter nodule? Should we be biopsying certain areas that may not be as concerning, which is very exciting now to have that change in landscape. This is a quick little 1-minute video of us doing the procedure so you can see what it looks like. You can see on the left of the screen, or the screen I'm looking at, is the virtual airway that the robot gives you. That's what it kind of digests and gets from the CAT scan. On the right of the screen is the real airway. What you have to do is tell the robot where the airway is. You'll do something called registration, going to the left main stem, bronchi, go to the right main stem, upper lobe, lower lobe, etc. And then the robot will kind of understand what's going on, think for a second, and give you a treatment plan or a path. Here you can see I'm just going to follow the blue line. It is pretty accurate, what helps us go, and you'll see all these bifurcations that traditionally can be very challenging to get to. A lot of people around the country don't have access to the robotic bronchoscopy, and they do things with just a bronchoscope in a dream. And they're very good at it, but they don't get the diagnostic yield we get here, which is, again, a testament to the advanced technology we have. After localizing the area and following the virtual target, we get an intraoperative cone beam CT image that'll help show our accuracy, and we're aiming something called tool and lesion confirmation, much like CT-guided biopsy does. Once we get that, we'll use the robot under fluoroscopic guidance to biopsy the nodule. This is a nodule right on the diaphragm, so a very precarious location. We can do this safely and accurately with a high diagnostic yield and a low complication rate. So a couple of cases very quickly. This is a case, one of my first 10 or 20 robots. I was still in the mindset of, can I get to this? It was a 3-millimeter nodule, grew to about 7 millimeters right on the fissure. I sent this to interventional radiology. They said, I don't want to go through 2 fissures. Our risk of complication is a little bit higher. So I think right now it's something we'd wait for it to enlarge and get bigger. So we went after it with robotic bronchoscopy. We went in with intraoperative cone beam CT imaging. This is a sagittal view of the CAT scan. You can see my robotic arm. If you can see my pointer, is that working? No, you can't. What about here? No. So up above that nodule, that blue circle is my needle, and to the left of the needle is my bronchoscopic channel, is the robot. You can see here I'm a little superior over the 7 mm nodule, so I knew that I was going to get a non-diagnostic biopsy had I biopsied there. With the advent of advanced imaging, I was able to move inferiorly because the robotic catheter fully articulates, and that allowed me to get a center strike. Because you can see here the needle's inside the lesion, right in the middle of the target. It is not touching the pleura, not touching the fissure. We're able to get a diagnosis of adenocarcinoma here. The patient did not have a pneumothorax. She went on to get a wedge resection and was cured of cancer. Traditionally, we'd have to wait for this nodule to increase for another modality to be able to go after it. But now, we're kind of hopefully stage shifting, going after smaller and smaller nodules and being able to get as early of a diagnosis as possible. Another one, this is which I think is very important. It is a 3 by 5 mm nodule that came from an outside hospital. The patient had a history of adenocarcinoma. This was worrisome to be recurrence of disease. So getting a timely diagnosis is extremely important because you're not able to restart therapy without getting a diagnosis. Now, traditionally, you would wait for this size to double to go after it, but with our new technology, we're able to do it. Here is the intraoperative images. This is, on the bottom left of the screen, is a 360-degree ultrasound. It shows that I'm close to the lesion, and under fluoroscopy, you can see it there. Intraoperative cone beam CT. The right of your screen is my bronchoscopic arm and a cryoprobe catheter touching the lesion. That made me feel more confident that I was going to get a good answer. I do have pathology at bedside who can tell me, I think you're in something, I think you're not in something. This came back as metastatic adenocarcinoma, and the medical oncologist could start treatment then and not have to wait 3 or 4 months for this lesion to double. So she was able to act on the patient's behalf much faster because we were able to get the diagnosis so much sooner. And an interesting case, this gentleman came in. He came after a dental visit. He had a chronic cough. The dentist said, it's probably nothing, don't worry about it. They ended up referring to a ER in Mississippi. They got a chest x-ray. You can see a metallic object here in the posterior basal area of his lung. There, at that hospital, it was a surgeon who was willing to do a wedge resection. The patient initially did not want a wedge resection, so the pulmonologist referred him over to us and transferred him over from hospital to hospital. We went in, again, nothing I could do that a surgeon can't do with surgery-wise. I can't take that out. So I tried at least. What I ended up doing was, here's a CAT scan of the same thing. Again, very, very far away, very distal. So traditional modalities could not retrieve it. Let me play this real quick. So we ended up playing the case with robotic bronchoscopy, and we're able to grab the metallic object and actually drag it through the working channel of the robotic bronchoscope. It took a little bit of time to kind of finagle because I was worried that if I dropped it, it would kind of, like a game of Plinko, it would just get back somewhere else in the airways and I'd never find it again. We were able to kind of successfully remove it. And any guesses what this was? Anybody know? Yeah. So dental drill bit, yeah, that's right. So this is one of the tools the dentists use. Typically, when I talk to one of the dentists, typically patients swallow it. They don't lose them very often. Typically, they swallow it. They tell him nothing to do. It comes out, and you're fine. Unfortunately for him, he was a little sleepy and inhaled it. So this kind of saved him a surgery, which was great for the patient, and it was a cool case that got us on the news. So very exciting. It was actually kind of funny because my mom got a dental procedure maybe like 2 or 3 weeks after that news story came out. And the dentist was like, yeah, some jerk is talking about how bad dentists are. And she's like, I don't know who that is. I'm not going to comment while you're inside my mouth. I'm going to stay quiet. But he was complaining about that to her, so that was kind of funny. I want to transition from more diagnostic to more therapeutics and how we can help the treatment team. Central area obstruction is a very dangerous disease that can happen to patients with lung cancer or metastatic other types of cancer. It can happen up to upwards of 50% of patients who have lung cancer can get some sort of airway obstruction. This can significantly decrease their quality of life, of course, and it can worsen their ECOG, so y'all aren't able to treat them or do things for them. We can go in and, a third of these will actually die from these complications. And bronchoscopic minimally invasive procedures are a mainstay of treatment. Typically, these are not surgical candidates. If they are, surgery is the mainstay, but if they're not, kind of typically they come to us. There are three types of obstruction. I'll very briefly go through them. One is intrinsic obstruction, where the tumor is confined inside of the airway. I go in, kind of like a plumber. I go in, core that area out with whatever tool I use. Don't have to do anything else, and the patient goes home that same day feeling better. There is extrinsic compression, as a large lymph node or large mass can squish or compress the airway. Typically, I'll go in, throw a stent in there, the patient will get better, and continue getting treatment. After treatment's done, I can hopefully take the stent out, and the patient can go on their way. The most complicated form of obstruction is the mixed, and that means there's an extrinsic compression that has eaten through the airway wall and now has become intrinsic. Those are a little more challenging to do, but again, we go in, remove the tumor as best we can, place a stent, and hopefully improve their quality of life so they can get treatment. This is just a quick array of some of the stents we can place. Nothing for y'all to really focus on, but they're silicone, metallic, covered silicone, uncovered metallic, a bunch of different kinds. And there's a Y stent in the bottom right corner if they have significant tracheobronchial disease. We can place those as well. There is some data of this. So they did a study where they found patients who came in intubated on mechanical ventilation because of their central airway obstruction. After they all went to rigid bronchoscopy and got that tumor intervened upon, about 2/3 of them had immediate discontinuation of mechanical ventilation, meaning they were extubated from the procedure suite and went back, and half of those patients actually stepped out of the ICU down to the medicine floor. So I'm usually caution our patients, you're likely, if I can do a good job, you're likely going to feel better after the procedure. And these are patients who I'll get from around the state where I'll do this as an outpatient procedure. They'll drive in 1 or 2 hours from wherever they're coming from. I'll do the procedure, put a stent in, and they go home that same day feeling much better, typically. They also did another study where they had patients with non-small cell lung cancer. They followed them. They had patients who had central airway obstruction and patients who didn't. And the ones who had central airway obstruction obviously passed away much sooner, but had they gotten intervention, they live as long as someone who never had any central airway obstruction, which doesn't sound that great to begin with when you think about it, but they're living as long as somebody else that has clear lungs, if that makes sense. And again, we can help make patients feel better, and also we can increase the ECOG by 1 or 2 points, making them eligible to get treatment or radiation or chemo when before they could not because they could not walk, and they spent most of the time in bed from their respiratory disease. A couple of quick examples. This guy was from back in IP fellowship. He came in from an outside hospital, never been diagnosed, kind of, chronic smoker, just felt more and more short of breath. You can see the right side is completely occluded. The mediastinum is going towards the right side. So if you remember, put on your old internal medicine pulmonary hat, it means likely a loss of volume, unlikely a pleural effusion. We got a CAT scan, something called the cutoff sign. You can see the right main stem completely cut off, indicating some sort of blockage, blood, mucus, or some sort of tumor. This didn't come as good as I thought it would come up. There's a large tumor right there, occluding the right main stem, and that's why his right lung was completely occluded. After tumor debulking, we placed a stent. You can see now that the healthy airway is visible. The stent is opening things up. He was able to go and get treatment afterwards. This is a chest x-ray after the procedure. You can see the right lung was more open. He still had some volume loss from where the tumor was originating, but we're able to open up 2 out of the 3 lobes. This is a crazy case that I found when I was, I think, my second year being an attending here. This is a gentleman who had squamous cell carcinoma. I think he came from Lafayette, if I'm not mistaken. He had a left pneumonectomy for his squamous cell carcinoma. Came back maybe 2 or 3 years later with worsening shortness of breath. The pulmonologist over there sent him over to me. Very salt of the earth guy. I kind of asked him, are you short of breath? He's like, no, I feel okay. And I'm having trouble believing that. And the more I talked to him, like, can you lay down? He's like, no, I can't lay down. No way. I couldn't lay down for a year. All right, can you walk? He's like, no, I can't really walk very much either. So I'm like, okay, I think you are probably short of breath. So we convinced him and took him to bronchoscopy. This is what we saw inside this is his trachea, right, the main airway. On the left is that sliver of black. That's where he's breathing from, which is absolutely insane, that he has 1 lung and 5% airway, essentially. We're able to get around that. We removed it in a very tenuous procedure, as you can imagine. This is it after the procedure. We removed the whole thing. You can see he's going to feel much better. We burned off the stalk from where it was growing from, and then 6 weeks later, we brought him back. It looks like nothing even happened. In post-op, he woke up and he goes, oh, you're right. I do feel better. No, I was short of breath. Forget everything I said. This is way better. Never mind. I'm sorry. is another patient who came from an outside hospital, came in. She was a DNR, but had history of small cell cancer that had progressed, and she came in on BiPAP and high flow nasal cannula, et cetera. We accepted her, took her for bronchoscopy. This is, again, for the main trachea, the trachea. You can see all that lumpy bumpiness around that trachea, very sliver-looking, very challenging. It's about 5 minutes in diameter, just kind of like an IP emergency. We went in, burned some areas that were bleeding, and used a balloon to open things up and placed a stent. This is it after the procedure. Again, patient was discontinued from BiPAP, discontinued from a high flow nasal cannula, went home off of oxygen. Again, she still has metastatic small cell lung cancer. I'm not saying she doesn't, but she's able to live another 3 or 4 months. She cooked dinner for her family and Thanksgiving and saw Christmas, and then passed away. Last but not least is the future directions that we're trying to go with. Again, this would be huge for my personal practice, is because I'm good at diagnosing, I'm good at palliating. I don't have a lot of options to treat. That's more for the surgeons and medical oncologists and radiation oncology colleagues. But bronchoscopic ablation is becoming a new avenue for a possible therapeutic option. I'm using a lot of ifs because it's still pretty experimental, but the pleural space is not violated, so you can compare that to interventional radiology, less pneumothoraces and better local control. Ideally, in my dreams, it's a one-stop shop, right? I go in, I diagnose the nodule, I stage the mediastinum. Mediastinum is clear, not a surgical candidate, not a radiation candidate. I'll go in and zap the tumor, and I can have local control. Many modalities are trying to access this space, and it's very challenging to figure out which one's going to be the front runner. We have microwave ablation, many different companies that do that, cryoablation, photodynamic therapy, and pulse electric field ablation. I won't go into too much detail, but each one has pluses and minuses. Not a lot of great data for any one of the modalities from a bronchoscopic standpoint. We're about to start a trial, hopefully the next 3 to 6 months, for microwave ablation. We're doing some cryoablation stuff, but again, nothing that I could say is really working yet. So overall, that's kind of it. This is our interventional pulmonology team, group of RTs that do this with us 5 days a week. My partner, Dr. Becknell, and our team. And yeah, so if you have any questions, I'm happy to field them now. And thank you all for your time. I appreciate it. Mm-hmm.
Any questions?
Dr. Abdelghani, that was an outstanding talk. One of the challenges first of all, I'm a major believer in robotic bronchoscopy, and that is now our first choice instead of sending patients to interventional pulmonary medicine, interventional radiology for the reasons that you mentioned. One of the Achilles heels, however, is the amount of tissue that one can obtain via the FNA in robotic bronch versus the core needle. What are your thoughts about cryobiopsy using the robot?
No, absolutely. And I think that is a challenge, right? Initially, you want to be able to get, first of all, the diagnosis, and second of all, the ability to get all the next generation sequencing, moleculars that oncologists will ever need. Cryobiopsy is a great avenue. For what it is, it's a freezing probe, uses the Joule-Thomson effect, rapidly expanding gas, causes a rapid decrease in temperature. Essentially, it obtains a lung popsicle, right? It goes in, freezes tissue, and removes it. It helps retain the architecture, so pathologists can make a better diagnosis. Two, it gives you a much larger amount of tissue. Traditional forceps can give you small amounts, where a cryobiopsy can give you up to 4 to 5 millimeters of tissue in aggregate. So this has been a mainstay of my bronchoscopies. If it's a larger lesion, I may use a forceps, but if it's small, like all these lesions I showed you, I'm definitely using cryobiopsy to get a better amount of tissue. And what I don't want to happen is I do not want to have to do this case again or this procedure again. So I try my best to make sure I have two-line lesion confirmation for negative predictive value in case it comes back benign, and to use all the modalities, needle, brush, and cryoprobe, to get as much tissue as possible. So far, I would say 95, maybe 98% of the time, there's enough tissue for everything, as far as I can tell, of course. Thank you.
Hi, Dr. Abdelghani.
How are you? Good to see you again.
Great. Nice to see you. I was curious about the risk of seeding in the CT-guided biopsies compared to the robotic bronchoscopies.
Yeah, that's a good question. And seeding has been theorized in CT-guided biopsies. There's a study or two that may potentially think this is an actuality. Robotic bronchoscopy, there is no data to support that there is any kind of seeding, as far as I know. But there are certain scenarios where you place chest tubes in melanoma or renal cell carcinoma or mesothelioma. There could be areas of or chances of seeding. We haven't seen much in robotic bronchoscopy, but it's a great question and great thing to kind of prospectively look at.
I have a question. You clearly showed good data that ion is superior to percutaneous biopsies with respect to complication. What do you think is the reluctance from either primary care doctors or pulmonologists who are following nodules to go towards or refer to ion and as opposed to watchful waiting or percutaneous biopsy?
I think it's twofold. One is culture. We've been sending the CT-guided biopsy for 30 or 40 years now, and it has been the gold standard. And in many cases, people think it is the gold standard, right? Second of all, I showed the data of conventional bronchoscopy. There are people like me, past versions of me 10, 20 years ago was like, yeah, of course I can get to everything. And the data showed that that is not the case. When CT-guided biopsy remains supreme. Then electromagnetic navigational bronchoscopy came out, and people said, yes, now I can do everything, send to me. And again, that was not the case. This is the third or fourth time we're telling oncologists and primary care doctors, yes, we can get to everything. This is, now data can actually show us we're actually able to get to everything. So it is it's person by person, I think, and case by case. You have to kind of change that culture. It is challenging, but I think now the data does show I'm comfortable. I've sent to IR maybe once or twice when they can't get general anesthesia. Otherwise, I've done over 1,000 cases, and we're maintained a 90-95% diagnostic yield and low complication rate. Cool. Thank you all.